Thank you for joining the ACCC Knowledge Series, addressing disparities in the diagnosis and treatment for biliary tract cancers. My name is Al Benson, and I am a GI medical oncologist and professor of medicine at the Feinberg School of Medicine at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. My presentation today will discuss evolving treatment landscape, molecular testing, and first-line therapy for patients with biliary tract cancers. A little bit about background. First of all, through the years, a chemotherapy platform was developed, and currently the standard platform is gemcitabine and cisplatin. Additional trials integrated immunotherapy in combination with gemcitabine and cisplatin. And I will be addressing the durvalumab trial. However, the pembrolizumab trial, which was one of the keynote studies, had very similar results to the durvalumab trial. Upon progression, FOLFOX has become a standard of care regimen, but increasingly, as is true across the oncology landscape, there is tremendous interest in better patient selection for treatment based on molecular mutations that can be targeted. If we look at molecular testing for biliary tract cancers, I would say that this has now become the standard of care. And what you can see here, there are multiple molecular alterations that cross the anatomic locations of the biliary cancer spectrum. And one aspect of the recommendation is to consider repeat biopsy or circulating tumor DNA analysis if you have insufficient tumor initially from a first biopsy to determine these molecular alterations. Also, if the primary anatomic site within the biliary tree is uncertain, comprehensive testing is recommended. And also consider obtaining FGFR2 fusion or rearrangement and IDH1 mutation testing in gallbladder cancer or in large tumors of uncertain anatomic origin within the biliary tree, because such testing may better inform and guide you for future treatment application. In addition, if we look at the incidence, we can see that, unfortunately, most of these molecular alterations are relatively rare events. The exceptions are FGFR2 fusion or rearrangement, which may be seen in up to 15% of intrahepatic cholangiocarcinomas and is rarer in the other subtypes. IDH1 mutation is seen in 10 to 20% of intrahepatic cholangiocarcinomas and also is rarer in the other subtypes. And then in addition, HER2 overexpression and or amplification may be seen in 5 to 20% of cholangiocarcinoma patients and 15 to 30% of gallbladder cancer. So testing for these various alterations is extremely important because we actually have therapeutic interventions. And as mentioned, I'll be reviewing some of these. By the way, because of the rarity of these individual subgroups, we can't be as precise in terms of incidence and frequency estimates as we would like to be. So just to review a current standard of care, And I'm going to first talk about the TOPAZ-1, the gemcitabine, cisplatin, and durvalumab study. And as I mentioned, the pembrolizumab study had very similar results, and I will not be reviewing the details of that particular trial. So in looking at systemic therapy options for biliary tract cancers, if we begin at the top for unresectable and metastatic disease individuals, first-line therapy options include as preferred regimens either durvalumab or pembrolizumab with gemcitabine and cisplatin. You can see there are other recommended regimens. So, for example, if it was not possible to treat the patient with immunotherapy, as I mentioned, gemcitabine plus cisplatin is a platform chemotherapy regimen. I should also mention if you felt that a patient should not receive cisplatin, then substitution with carboplatin would be reasonable in combination with gemcitabine. Some people also do consider FOLFOX in this setting, or gemcitabine with albumin-bound paclitaxel, or gemcitabine plus capecitabine. But I think overwhelmingly, the majority of patients would be considered for the preferred regimens. For those who undergo disease progression, there are subsequent line therapy options, and FOLFOX really dominates as the preferred regimen, although here too there are some alternative regimens for consideration. So now I'd like to summarize the TOPAZ-1 study, which was the study which was evaluating gemcitabine with cisplatin with either durvalumab or placebo. And you can see on the right the schedule of administration, which was every 3 weeks. However, in terms of the chemotherapy, patients received up to 8 cycles, after which they continued durvalumab or the placebo until there was disease progression. This was a double-blind, multi-center global phase 3 study. You can see the eligibility. These patients could have intrahepatic or extrahepatic cholangiocarcinoma or gallbladder. They were previously untreated, although patients who had received surgery or adjuvant therapy were eligible, providing 6 months had passed in terms of their diagnosis with recurrent disease. And the primary endpoint here was overall survival, which was certainly appropriate for a disease as lethal as cholangiocarcinoma, and for which, after first-line therapy, there are limited options. The primary endpoint was overall survivorship, and what you can see here, that the study was statistically significant, favoring the addition of durvalumab to gemcitabine and cisplatin with a hazard ratio of 0.8. And then if you look during the course of events here on the Kaplan-Meier curve, you can see when you look at 12 months, 18 months, and 24 months, overall survivorship was most beneficial for the durvalumab combination. Unfortunately, very few patients do survive at that 24-month endpoint. There was also a 3-year update of the TOPAZ study that was published last year. And what you can see is that the data continue to hold true, demonstrating the superiority of the combination. There was also secondary endpoints, including tumor response. And here you can see there was some difference in response overall favoring the combination with durvalumab. There were some increased PRs for those with the durvalumab combination compared to placebo. The disease control rate was not strikingly different, however. And then if we look at progression-free survival, you can see that there also is a difference, which was statistically significant. There is significant interest in looking at real-world data. And there has been a recently published real-world data population study looking at durvalumab plus gemcitabine and cisplatin in advanced biliary tract cancers. This was a fairly large evaluation of over 600 patients. And what you can see here, that the median overall survival was quite impressive at 15.1 months, and PFS was noted at 8.2 months. And then you can see in the pie chart the breakdown here in terms of response rates. Then there was a look at the data dependent on location, and you can see that in this population, perhaps the extrahepatic patients fared a little bit better with the combination. And here we look at cisplatin, gemcitabine, and durvalumab compared to cisplatin and gemcitabine. And what you see here is that the combination, again, appears to be superior when compared to the chemotherapy platform. So I wanted to mention at least some of the targeted therapeutic options. I'm going to focus today on IDH1 and FGFR2. However, we also have additional treatment options with targeted therapies based on molecular determination, and therefore further emphasizing the importance that all of these individuals should have NGS determination. So if we look at the landscape of targeted therapies, so again, if we look at unresectable and metastatic disease first-line treatment options, as I showed you previously, most of these molecular events are relatively uncommon. But what you can see here, if in the rare set of circumstances someone has an NTRK gene fusion positive tumor, we actually have multiple drug options. And certainly if a patient has an MSI-H or deficient mismatch repair tumor, immunotherapy is a potential option. And then for disease progression, again, we have a host of treatment options, including those who may have a BRAF V600E mutation. And then you can see across the board multiple options based on tumor biology. And I would encourage you to be very familiar with guidelines and these treatment options for patients. And it's why having the NGS information up front is so important to inform decision making. So if we briefly look at the ivosidenib study, uh, in this case, it was placebo-controlled, although a 2-to-1 double-blind randomization with 187 patients. Crossover was permitted when there was evidence by imaging that there was clear progression. And the eligibility included histologically confirmed cholangiocarcinoma. They must have had IDH1 determination, a good performance status, and they should have had 1 to 2 prior therapies, and at least one should have included gemcitabine or 5-FU, and they had to have measurable disease. And what you can see here is on the left, this is the placebo group, and on the right is the ivosidenib group. And clearly you can see by this swimmer's plot that there were individuals who had durability in terms of disease control. If we look at progression-free survival with the placebo control, you can see that there was clear benefit in terms of disease control rate favoring the drug intervention. So if we look at an example of a pemigatinib study, this trial had 3 cohorts. One group had FGFR2 fusions or rearrangements. Another had genetic alterations of FGF or FGFR. And then the third group did not have evidence of genetic alterations. And so these individuals had to have documentation of their FGF or FGFR status. They had to have had at least one prior therapy to participate. And you can see the dose of pemigatinib 2 weeks on and 1 week off until progression or toxicity. In terms of these cohorts, this just simply shows the overall cohort inclusion. And what you can see is that the largest group was the cohort A group with the FGFR rearrangement. If we look at the waterfall plot, you can see the significance of the response rate for this population. Also, if we look at the 3 cohorts, you can see really it's only those with FGFR2 fusions or rearrangements who have a significant benefit from treatment with this targeted agent. And this looks at, also at the overall survivorship, which really matches with progression-free survival. That it's really the FGFR2 fusion or rearrangement population who should be considered for this type of intervention. I'd like to talk a little bit about disparities for individuals with biliary tract cancers. So there's really tremendous interest in continuing research and clinical trials for people, and to make sure that these trials are all inclusive of populations. So what we have to keep in mind in looking at the population of patients with cholangiocarcinoma, and certainly when we're designing trials, that if we look at survival indices, certainly there's, as I showed you, there's lower disease-specific survival among minorities. In terms of treatment, the Black race and uninsured status negatively correlates with adequate treatment. There is underrepresentation of minorities in clinical trials. Unfortunately, there has been some wrong classification of cholangiocarcinoma in some databases, and also lack of uniform reporting of cholangiocarcinoma subtypes. So these and other factors are increasingly important to consider as we conduct research evaluating this population of patients. That could include looking at real world evidence, but also as we design clinical trials for patients. And it puts an emphasis how important social determinants of health, for example, are in terms of outcomes for our patients. And this is not only true in cholangiocarcinoma, this has been demonstrated certainly across GI cancers. There are opportunities for improvement in terms of research opportunities for those with cholangiocarcinoma across our populations of patients. And this is in recognition that we need to reduce racial disparities. We need to improve survival outcomes for the minority populations with cholangiocarcinomas. And this will require looking very carefully as we design trials. We need to, across groups, make sure we have good data looking at, for example, the molecular features and tumor biology of cholangiocarcinoma, and where necessary, particularly as we bring in these populations that have been poorly represented, to recognize that there are factors where assistance may be required, trying to address some of the social determinants of health to make sure people have equal access and equal opportunities for treatment, including clinical trial participation. Also, there has been some work looking at considerations for cancer screening in an immigrant population. So, for example, in cholangiocarcinoma, to identify high-risk groups for biliary tract cancers. So this can include liver fluke infection based on region of origin. And that, of course, includes Southeast Asia, including Thailand, Northern Vietnam, and Laos, as well as East Russia and Northern Siberia, South Korea, and certain areas in mainland China and Taiwan, as well as looking at exposure history, such as eating raw or fermented freshwater fish. Also to evaluate for liver fluke infection with complete blood count with differential, and stool testing for ova and parasites, particularly from patients who are from endemic areas, also with a history of biliary tract stones or dilated intrahepatic bile ducts without obstruction. So this becomes important. We do have a very diverse population in the United States, people who do come from these other parts of the world. And so considering etiology is important. Also, there has been some work looking at nursing advocacy actions and barriers. So, for example, the importance of language, the importance of documenting the meaning of genomic health terms with the recipient. So they have a clear understanding of their diagnostic testing, including NGS results, um, involving experts preferred by the patient or an at-risk community member, which could include an advocacy organization, uh, members or family members, to use culturally appropriate genomic health education materials, and to also recognize risks for societal harm from unintended interpretation of genomic information. In terms of access, to try to use navigator models to minimize barriers, and also to partner genomic specialists with healthcare providers at point of care wherever possible. Also, the importance to engage community leaders in addressing gaps in quality care, determine what outcomes matter to underserved communities, health systems, and payers, as well as to develop or apply existing measurement instruments as common data elements to build evidence bases to document outcomes. Also, the importance of financial toxicity. Um, Many of our therapies are increasingly expensive, and as patients live longer, stay on treatment longer, these financial considerations are becoming increasingly important. So financial toxicity is a growing area of cancer research. And it does highlight the importance of financial counseling and to be able to provide that for our patients. It's very important to review with patients what insurance will cover and related copays. For many patients, these copays are a real significant barrier. And informing people, for example, if they qualify for assistance programs, can be very, very beneficial for individuals. Diagnostic companies are often willing to forego payment or work on a payment plan, including reduced charges for NGS testing, and that certainly should be explored. And some clinical trials will provide testing, and this can reduce potential costs to patients. So I hope this brief presentation provided you with some perspective on the possibilities of treatment for cholangiocarcinoma. Certainly over recent times, the landscape has changed dramatically, and there has been great enthusiasm for conducting clinical trials for our patients with bile duct tumors. And I would certainly urge you to know what trials are available to you and to participate in these important trials to advance our progress. And then also to emphasize that comprehensive cancer care is really important for all of our patients. And that not only includes access to all the specialists who are important for people's care, having access to important diagnostic tools such as NGS testing, but also we need to be cognizant of barriers that patients face. And this is the importance of social determinants of health and how we can provide resources for our patients, work with community members so that all patients have adequate access. I thank you very much for watching this educational session. I am very appreciative of our sponsors and collaborators on this presentation, particularly the Cholangiocarcinoma Foundation and also the generous support from AstraZeneca. Uh, Thanks very much for your attention.